Can you guys see it?
Yes, if you can just put it in slideshow mode,
Sure.
please.
All right, better?
Perfect. Thank you.
Well, thank you so much for having me today. I think it's so important to kind of look at the different cancers and how we can prevent them. So let's start with colon cancer prevention. So this is me. Like you mentioned, gastrointestinal tumors are one of my specialties. Let me just remove this part from here. Okay. So a little bit about me, born and raised in Canada, did a bunch of from Montreal to St. George's Medical School, did my residency and part of my fellowship back in Pennsylvania, went home to complete it, and I've been at MCI for about 3 years. So I think it's important to kind of go through the incidence and the risk factors and the symptoms and diagnosis and treatment options, and then to really understand why is it that we want to prevent colon cancer and how is it that we can, and to figure out what are the signs and symptoms that would lead one to kind of raise an eyebrow as to saying, let's see what we can do and let's see what the symptoms are. So let's start. So colon cancer is a common and it is a lethal disease. In the US alone, approximately each year, about 150,000 new cases are diagnosed. And with that, about 50,000 Americans die of this disease. So it's a rather large number. So what is it that we can do? Since 1990, mortality has been declining, which is a good thing at about 1.2% per year. But overall, it still remains the third most common cause of cancer deaths in women and the second leading causing deaths in men. Now, what is the caveat to this and why we're changing our screenings, why we're talking about prevention, is because the incidence of the age group under the age of 50 has been increasing. So despite the overall incidence of all ages has noted to be on a decline since 1990, if you delineate between the age groups, the age group of under 50 has been increasing at about a rate of 1.2% a year. So with that being said, this is the graphs of the year 2020. And I highlighted the age groups between 20 and 39 and 40 and 49. As you can see, this is looking at male sex. That is the #1 cause of cancer deaths in the US. If we look at females, it becomes the third and the second leading cause of deaths within these age groups. Now, this is for the year 2020. If we look back at 1 year in 2019, it was, again, this is for men, it is the third and the second leading cause of deaths. So from 1 year difference, you can tell that the increase of patients under the age of 50 has been increasing. If we look at female only, that has the third most common and the third most common in the year of 2019. If we backtrack to the graphs that I showed previously in 2020, it has become the third and second leading cause of deaths in female. So each year we're seeing that there has been a steadily increasing amount of incidence within younger patients. So how is colon cancer diagnosed? A, if you have symptoms, or if we could do a screening colonoscopy. Screening colonoscopies are the standard of care. It's the gold standard of how we diagnose colon cancers. Or say, for example, you have a stool sample that you want to give your primary care physician to do what we call a FIT test, and it looks for any occult blood within the stool. That would then lead for you to get a colonoscopy. So there's a non-invasive and an invasive way to kind of screen for colon cancer. This is just a schematic. The arrows are showing you on a plain CT of what colon cancer can look like if we do an imaging. And the picture in B on the right-hand side is showing you a direct picture from a colonoscopy. So what are the symptoms? Abdominal pain is one of the biggest symptoms that we have that patients report. So this is due to a tumor sitting in your colon, causing pain, causing an obstruction. And sometimes the tumor can grow and grow and grow, and it can perforate. So that can cause instant and acute abdominal pain that would lead one to go to the emergency room. Say, for example, you've had great bowel movements for, all your life, and all of a sudden they become super thin, looking like a pencil. There are changes in size. So that is a sign that there could be a mass that is sitting in your colon. If, for example, you see really, really dark stools or any blood that when you wipe, you're like, is this hemorrhoids? I don't know what this is. Always ask your primary care physician and seek medical attention, because rectal bleeding is a symptom and a sign of colon cancer. Another sign that, when we do routine blood work, we go for our general physical, we see our primary care, we do blood work, and we see that we're anemic. We have no symptoms, we have no signs, we have no pain, we have no change in bowel habits, we have really nothing that would kind of lead us to say, what's going on? If you're diagnosed with iron deficiency anemia and you do a workup and you have no cause for it, that is one of the presenting symptoms. So that would lead one to then get a colonoscopy. We just talked about abdominal pain, but that is the single most common symptoms that patients will report. So how do we screen? Again, asymptomatic patients, early, we can detect malignancies at a really, really early stage. So that's why we always recommend screening colonoscopies. And it's the only way that we can diagnose colon cancer at an early stage. If we can diagnose you at an early stage, we can provide a cure. So that's why we're very, 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 very big on promoting prevention and screening in colon cancer. Previously, our guidelines was to screen everybody at age 50, the general public at age 50, or if you were to have a family history or other confounding risk factors, we would do it a little bit earlier. But based on the graphs that I just showed about the incidence of colon cancer increasing in younger patients, we've changed all of our screening guidelines. So now every adult should get a colonoscopy at age 45. This excludes if you have a family history of colon cancer or if you have a genetic predisposing condition that would lead to different screening at an earlier age. However, for the general public, the new screening guidelines are age 45. This can help with us getting treatment done earlier. It can provide a cure. So if we can diagnose you at an early stage, stages 1, 2, and 3, meaning the cancer has not spread to anywhere, we can provide a cure. So screening actually saves lives. The treatment tends to be based on what stage we are, but we give a little bit of chemotherapy after the surgical resection of an early stage colon cancer to help prevent the cancer from coming back. And what's unique about colon cancer is even if you were diagnosed at a stage 4, meaning you had your primary colon cancer and say you have a lesion in the lung or a lesion in the liver, there are some cases that we can still provide a cure even at an advanced stage. So just a quick summary of what we just discussed was the incidence, symptoms, diagnosis, and screening. But what else can you do besides getting a screening colonoscopy at age 45? Well, there's risk factors that you can help to do at home, which means exercising. So really get moving, exercise daily, whether it means walking, going to the gym, doing a light weight activity, movement, getting, losing weight, maintaining a healthy weight. In addition to that, if you smoke, stop smoking. Smoking is actually one of the risk factors for many cancers, not only colon cancer. If we look at our dietary intake, making sure that your diet is filled with fruits, with vegetables, with a lot of water intake. The other thing too is knowing your family history. So say, for example, one of your first degree relatives has been diagnosed with colon cancer at age 45, we would recommend that you are diagnosed with that you get a colonoscopy 10 years earlier, which means at age 35 in this example. So family history is very, 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 very important. The other thing that we went over is your symptoms. So say you had your screening colonoscopy at now age 45 and you're 52 and you're starting to have a lot of abdominal pain or bloody stools and you're not sure what's going on. The fact that now you kind of know the symptoms of colon cancer, that would lead you to then get an earlier colonoscopy at that time. So always, 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 if you have questions, seek medical attention, ask your primary care physician to see what's going on. Okay, so this is just a pie graph to really know that colorectal cancers can be prevented with screening, and there are risk factors that you can modify with your lifestyle, which means working out, maintaining an active lifestyle, moving in any which way, eating a healthy diet, rich in fiber, those types of things, and water. limiting the amount of alcohol, stopping to smoke. And the biggest thing is also knowing your family history. So about 50% of these colorectal cancers can be screened. So exercise, eat healthy, quit smoking, drink in moderation, maintaining a healthy lifestyle, knowing family history, and getting your screening colonoscopies at age 45 are the key main things in helping us prevent colon cancers. So thank you. I'll save questions for the end of the presentation, and I'll have, I think it's Dr. Kaywin will be next.
Thank you, Dr. Joseph, for all of the valuable information. And yes, I'd like to invite our second expert, Dr. Kaywin, who will discuss lung cancer prevention. So Dr. Kaywin, if you'd like to go ahead and start sharing your screen.
Yeah, Sarah, can you stop sharing?
Oh, yep, absolutely. There we go.
And thank you again to all of those who joined us so far. If you do have any questions, please type them in the chat or the Q&A box, and we will address them during the Q&A session at the end of the presentation.
Great. Can you see my screen?
We cannot.
Screen share. Hold on. How about now?
Perfect. And if you can just put it in slideshow mode.
Yeah, let me just see where that is. Is that in slideshow mode now?
Now just click from beginning at the left. There we go. Perfect. Oh, if you can just click on from beginning.
Okay.
Perfect. Thank you, Dr. Kaywin.
Okay, so I have no disclosures. I'm one of the thoracic medical oncologists here at MCI. Thank you for allowing me to participate. So in order to understand prevention for lung cancer, we need to get an idea about the scope of the problem and review lung cancer risk factors, and then we can review what can be done for risk reduction and risk prevention. We have a huge problem with lung cancer. As you can see on the graphic on the top, the incidence of lung cancer is the second most common cancer in men, 12% over 117,000 cases. This is in 2022, in women, 118,000. So it's the second most common, but what's most important is the bottom graphic, which shows that of all the common cancers, lung cancer in men and women is by far and away the highest cause of deaths from cancer. 21% of cancer deaths in men and women are from lung cancer, which is far and away much higher than all of the other common cancers. Why is it? Why is lung cancer death rate so high? It's because lung cancer is silent. Due to lack of early symptoms, most lung cancers, 75%, are not diagnosed until they're at a more advanced stage. Survival in lung cancer depends on the stage. Cancers detected at an earlier stage, at a lower and earlier stage, have a higher cure rate. So on the graphic on the right, we see survivability from 100% down to 0% over 72 months, about a 6-year period. And all these lines represent the stage of lung cancer. And we see that the top lines are early stage lung cancers, what we call stage 1, small cancers that can be removed surgically, and the cure rate can be as high as 92%. As we go down, we see larger cancers, more advanced cancers, and the cancers that are diagnosed most commonly tend to be down at the lower end of the graph, which are stage 3 cancers spread to the local lymph glands, or metastatic cancer, stage 4, where the cure rate is almost 0 or less than 10%. Now, we are doing somewhat better with lung cancer. This graph charts show in men on the left and women on the right the death rate from lung cancer spanning from 1930 till 2020. The top line, the top blue lines, the top line on the left and the top line on the left are lung cancers. And we can see that since about 1990, the death rate from lung cancer has been going down in men and women. And we believe this most likely correlates to decreased smoking rates. So let's start talking about what are the risk factors. Well, cigarette smoking is by far and away the most important risk factor. Approximately 80% of all lung cancers are smoking related. The longer someone smokes and the more packs per day increases the risk. We all have about a lifetime risk, smokers and non-smokers, of about 1 chance in 15 for men and 1 in 17 for women of getting a lung cancer. But heavy smoking can increase the risk by up to 30%. And unfortunately, in 2020, still about 14% of men and 11% of women in the country still smoke. Cigar and pipe smoking also increases the risk for lung cancer, as well as other oral cavity and head and neck cancers. Other risks, what about radon? It's felt that radon may be the second leading cause of lung cancer. Radon is a naturally occurring odorless radioactive gas that results from the breakdown of uranium in soil or rock. It's not so much an exposure for the outdoor risk, but if a building or a home is built on top of an area that's emitting radon, especially the basement areas of those structures, inhalation risk can be significant and can increase the risk for lung cancer. We see on the graphic of the country that different parts geographically of the country have different risks. The yellow are the lowest areas of radon. Florida tends to be mostly in the low risk areas. Some other areas in the red are much higher. And in the graphic on the right, we see more details for the state of Florida. In this graphic, green are areas of low risk where the radiation radon level is less than 2 picocuries per liter. Yellow, including Dade County, is moderate risk where it can be between 2 and 4 picocuries. And then the high risk, there are a few high risk areas in the panhandle where it's above 4 picocuries. Other risk factors. We've now learned over the past 15, 20 years or so that there can be spontaneous non-hereditary mutations that can occur in the lung cells of light smokers or never smokers that can cause lung cancer. In non-Asians, 10 to 15% of lung cancers, and in Asians, up to 30% of lung cancers in light or never smokers can be caused by these so-called driver mutations. The presence of these mutations in normal lung cancer cells drives them or signals them to grow as cancer. Testing for these mutations at the time of diagnosis has now become standards. It's very important since there are now specific targeted treatments for some of these mutations. Secondhand smoke exposure can increase the risk of lung cancer by 20 to 30%. It's estimated that approximately 7,300 lung cancers a year in the United States is from secondhand smoke. Other risk factors, asbestos. Asbestos is a naturally occurring fibrous silicate material that's used to strengthen and fireproof materials. So inhalation exposure is a risk for those people working in mines, textiles, shipyards, automotive workers where brake liners used asbestos, or older buildings where asbestos materials were used. Asbestos can increase the risk for the common types of lung cancer, but more importantly, there's a risk for a less common lung cancer called mesothelioma. And other environmental exposures that can increase risk of lung cancer include air pollution and inhaled chemicals. What about just general radiation? So we're in the United States, we're all exposed to a certain amount of cosmic environmental radiation on the level of 6.2. The measurement is in millisieverts. So to put that in context, a chest X-ray, one chest X-ray gives an exposure of about a 1/10 of a millisievert, and it's estimated that 36 lifetime chest X-rays can slightly increase the risk of cancer by 0.05%. Airport scanners, it would take 1,000 to 2,000 airport scans to have the equivalent of one chest X-ray. Airplane flights, the higher you are in the atmosphere, the more radiation exposure there is, and a flight from New York to Los Angeles can give approximately 0.035 millisieverts. What about radiation exposure for therapeutic radiation, people that receive radiation to treat other cancers, such as breast cancer or Hodgkin's or other lymphomas, where the lung can sometimes catch some of the radiation, and there can be increased risks of late lung cancers after such treatment. Newer radiation techniques are now much better at sparing the normal lung. And we know that chronic inflammation in the lung from other non-cancerous diseases, such as TB or pulmonary fibrosis, can increase the risk of lung cancer. There are other areas of risk that are of uncertainty. This is a busy slide. I'm not going to go through everything in detail, but suffice it to say that there's no genetic hereditary gene for lung cancer. There can be some differences in race between the risk of lung cancer. Hispanics tend to have a lower risk, but finding out about this has been difficult because different racial groups have different smoking history. There's not been any proof that any specific diet increases the risk of lung cancer. Diets higher in fruit and vegetables are thought to hopefully reduce the risk of lung cancer, but that's never been proven. Marijuana and vaping, both smoking marijuana and vaping e-cigarettes, there are concerns that the inhalation, even though it's not cigarette smoke, can contain carcinogenic chemicals. But there's never to date been proof or a definite study linking marijuana smoking or vaping to lung cancer. Both marijuana and vaping has been shown to cause other non-cancerous injury to the lungs, such as bronchitis or asthma. So now let's move to what can we do to reduce our risks. So clearly the most important factor that anyone can do to reduce their risk is either to not smoke or to stop smoking. Cessation of smoking, especially after 5 years, reduces the risk. After 15 years of cessation, the risk reduction can be as much as 80 to 90%, but still remains somewhat higher than never smokers. Smoking reduction, but without quitting, may have some risk reduction. Why is it so difficult to stop smoking? It's because nicotine is addicting. So there are aids to help quit nicotine replacement therapies, replaces the nicotine craving without the exposure to the carcinogens in cigarette smoke, with the ultimate goal to substitute a nicotine replacement therapy and then taper off. So nicotine comes in patches, gum, lozenges, nasal spray, and inhalers. Other things, other methodologies to help quit smoking include behavioral counseling. There's medications such as Chantix and Zyban. What about vaping? Vaping is controversial. In some smokers say that transitioning from cigarettes to vaping has helped them to get off cigarettes. And on this slide on the bottom, I've listed the places where people can call by phone or online to get help for quitting smoking. And of course, avoiding secondhand smoke exposure is a risk reduction. Other things to reduce risk of lung cancer, of course, is to lower workplace risk factors of exposure to asbestos or inhaled chemicals. What about radon? So Florida does have statutes that require for certain state licensed facilities and foster homes to test for radon, but it's not mandated for residential homes. Buyers of a residential home can request radon testing with their home inspection, and the Florida Department of Health can supply a radon test kit. As I mentioned, less than 4 picocuries per liter is considered safe. And here is a website where you can get more information about radon and can look for information in Florida. Now, lastly, what about people that smoke and who are at risk? Is there anything that we can do to try and detect cancers earlier so that they can be more curable? We know that routine chest x-rays are just not accurate or sensitive enough to detect early lung cancers. However, there have been 2 large, well-run trials. One is the NLST trial, and the other is the Nelson trial, that have definitively shown that low-dose screening CAT scans in those at risk. And what do we mean by those at risk? That's age 50 to 80 with a 20-pack year or more smoking history, meaning smoking 1 pack of cigarettes a day for 20 years or 2 packs a day for 10 years, or anyone with that smoking history who was within 15 years of quitting. That has been shown in these studies, the mortality rate from lung cancer can be reduced significantly by 20% through earlier detection of potentially curable cancers. And based on this information, several cancer advocacy groups are now recommending that CT screening for this risk group become standard. Medicare does reimburse for it. And on my slide at the bottom is where we have at Baptist and the Miami Cancer Institute to contact for low-dose screening. So I will end there and be available for questions. Thank you.
Thank you, Dr. Kawin, for the valuable information. Up next, we will invite Dr. Dempsey, who will touch on breast cancer prevention. So I'd like to welcome Dr. Dempsey.
Hi, everyone. Pleasure to be here with you today. So, able to see my screen?
Yes, if you can just put it in slideshow. Perfect.
Wonderful. So my name's Naomi Dempsey. I'm a breast medical oncologist with Miami Cancer Institute, and I practice in Plantation, Florida. So let's start off with some of the basics. What is breast cancer? Breast cancer is cancer that starts in the breast, and it can start in one breast, it can start in both breasts, and even if a breast cancer has spread to other parts of the body, such as bones or liver, that is still considered breast cancer. Breast cancer can come from any of the parts of the breast. The most common part that we see it start from are the milk ducts, which are basically like pipes that take the milk from where it's made out to the nipple. It can also start in the lobules where the milk is made, and we call that a lobular cancer. And less commonly, it can start in the nipple, it can start in the fat of the breast, in the blood vessels, and in the lymph vessels. Ductal carcinoma, so again, coming from those tubes in the breast, is the most common type of breast cancer. And I think it's important to note here the difference between an invasive breast cancer and a non-invasive breast cancer, and since this is something you may hear about. An invasive breast cancer is one that you see here on the right, where the cancer actually invades through the walls of the tube in an effort to escape, get out to lymph nodes, get out to other parts of the body, as opposed to the middle picture that you see that is what we call ductal carcinoma in situ. This is a non-invasive type of breast cancer where, yes, there are cancer cells inside the tube, but they're not trying to invade through the wall of the tube or get out to other places. So no one dies of DCIS, but it is important because it's a marker of risk for future invasive breast cancer. So generally, people do receive treatment for DCIS. In terms of the stages of breast cancer, stage 0 is what we were just discussing, the DCIS, ductal carcinoma in situ, that there are cancer cells, but they're not invading anywhere. A stage 1 is going to be a small tumor with no lymph nodes. A stage 2 would either be a little bit bigger tumor, or maybe there's a couple of lymph nodes in the armpit that are involved. Stage 3 is if the tumor is quite large or if there are a number of lymph nodes involved. And stage 4 is if it spreads to other places like bones, liver, lungs. And that's what we call metastatic breast cancer. So anyone can develop breast cancer, and as you've seen in some of the other slides earlier, breast cancer is the most common cancer amongst women. Over 250,000 cases are diagnosed in the United States every year. 1 in 8 women will get breast cancer in her lifetime, and breast cancer also can develop in men. About 1% of all of our cases of breast cancer are in men. So it's still important for men to be aware of their breasts and bring any kind of lump to the attention of their physician. So there's 2 different types of risk factors for breast cancer. One is the type of risk factors that you're born with and that there's really nothing that you can do to change those. And then there are risk factors that we can do something about. So the risk factors that we can't really change are our age. As we age, the risk of breast cancer does go up. If a patient has previously been diagnosed with breast cancer, they are at higher risk. If they have a family history, which we'll talk a little bit more about, if they've inherited a gene, such as the BRCA gene, that puts them at higher risk of breast cancer, if women wait to and delay pregnancy, a history of ovarian cancer, if menstruation starts very early or menopause occurs late. And we have found that amongst certain ethnicities, such as Black patients, there is a higher incidence of breast cancer and higher mortality. So that's something as a field that we are really working to address. Specifically in terms of family history, I echo what my colleagues have said earlier, that it's really important to know your family history. A lot of times I'll ask patients about family history and they'll say, well, grandma had bone cancer and we really need to get further detail. Is it a breast cancer that started in the bone or did it start somewhere else? What age did their cancer get diagnosed at? So make sure as you talk with your family members, you press for a bit more details. If you have one first-degree female relative, meaning a mother, a sister, or a daughter, that is diagnosed with breast cancer, your risk is double. And if you've got two such relatives, then your risk is 5 times higher. And if you have a man in your family that you are related to that has breast cancer, you also have increased risk. So talking a little specifically about the BRCA gene. So everybody has BRCA genes, but what we are specifically referring to is a mutation in the BRCA gene. There are 2 different BRCA genes that are important for breast cancer, BRCA1 and BRCA2, that have normal functions in the cell, but when they get a mutation, when someone is born with a BRCA mutation, they are at an increased risk of breast cancer that can approach 70% lifetime risk of developing breast cancer. So we commonly do genetic testing for patients that we think might be at risk. It's a blood test, it's simple. And it does affect what we recommend for you in terms of screening and intervention. So we certainly discuss with women the option of doing a preventive mastectomy on both sides, what we call a prophylactic bilateral mastectomy. Obviously, this is a very difficult decision for women to make, and it's something where we as physicians really partner with the patient to help make these decisions together. Not one decision is necessarily right for everyone, but between the ages of 30 to 40 is where we are talking about risk-reducing mastectomy to prevent a breast cancer. These mutations also carry a risk of ovarian cancer, so we are discussing removing the ovaries once childbearing is complete, depending on which BRCA mutation you have, somewhere between the ages of 35 and 45. But certainly there are women that are going to say, this isn't for me, and that's okay. And if that is the woman's decision, then alternatively, we would do a more intensive screening program that would involve both mammograms and MRIs. The MRI would start at age 25 and mammogram would start at age 30, and we would alternate them. So you get each once a year, but we alternate them every 6 months. You get a mammogram, 6 months later MRI, 6 months later mammogram. Importantly, the risk factors that you can change, and a lot of these really mirror the other preventive risk factors that you've heard earlier today. So the most important one is controlling your weight. Many breast cancers are driven by estrogen, and after menopause, estrogen is made in the fat. So the more body fat that we have, the more source of estrogen there is. And so it's very important to maintain a lean body weight, being physically active towards that end. Limiting or avoiding alcohol, as this is a risk factor for breast cancer. Breastfeeding is actually protective. So if you've got interest to breastfeed, that is helpful in terms of breast cancer risk, and don't smoke. So for breast cancer screening, really the mammogram is the very most important part of breast cancer screening. And we do have a couple of different guidelines that differ slightly in their recommendations. The American Cancer Society recommends mammograms starting at age 40 and repeating them annually. And that generally is also my recommendation to my patients. We have the United States Preventive Services Task Force that recommends mammograms starting at age 50 and performing them every other year. So certainly by age 50, we need to be starting mammograms, but I would advocate starting earlier than that. Mammograms are basically an X-ray of the breast. The breast does get compressed, which can be uncomfortable. And then an X-ray is taken. The radiologist, who's the physician who looks at the images, then generates a report telling us what they saw. And oftentimes, they are going to be able to tell the difference between something benign, like the cyst that you see here in the upper right, versus something like cancer. But if they're not certain, just based on the images that they had, you might get a call back. And it is pretty common to get called back. And it doesn't necessarily mean that you have breast cancer. It just means the radiologist maybe needs a dedicated view for that spot. Maybe they want an ultrasound in addition. And fewer than 10% of women who get called back ultimately get diagnosed with breast cancer. So not a cause for panic, but certainly something to address if you get a call back. So we use ultrasounds and these specific diagnostic mammograms to get a special look at something. At times, our radiologists want a breast MRI, and if they really feel that something is suspicious, the breast radiologist will perform a biopsy of the breast. Ultrasounds are particularly helpful if you've ever been told that you have dense breast tissue. If that's the case, your screening mammogram should also include an ultrasound. And like we discussed earlier, if you are a BRCA carrier that opts not to do a preventive mastectomy, MRI should be part of your screening. Treatment is very individualized if you're diagnosed with breast cancer. It depends on the stage. It depends on the factors that drive the breast cancer, but can include any or all of surgery, radiation, chemotherapy, and pills to affect hormones. And of course, your preferences are taken into account as well. And we work together to come up with an individualized treatment plan. And thankfully, breast cancer outcomes are excellent in 2023. The survival rate, 5-year survival rate for local breast cancer is 99%. And even for a breast cancer that's spread to lymph nodes, the 5-year survival rate is 85% and improving on a regular basis. So if I were to give you 5 kind of take-home recommendations for things you can do today to change your breast cancer risk, number 1 would be get your mammogram on time. We see a lot of women who delayed mammogram during COVID and then ended up with breast cancers that were more advanced and somewhat more difficult to treat, as opposed to if they had had their mammogram on time. To that end, establishing a relationship with a primary care doctor or a gynecologist who's going to be your partner in making sure your mammograms are on time, ordering them, getting insurance approvals, kind of taking care of that side of things for you, and someone that then you're able to go to if ever you notice a problem in the breast. Maintaining a healthy body weight, know your family history, and really be an advocate for yourself in your healthcare. The medical system is complicated, and I think every patient needs to be an advocate for themselves. And family members are a huge support. So if there's a loved one in your life who has a diagnosis of cancer, be their advocate, because we all need an advocate in our healthcare system. And thank you. It's been a pleasure to be here with you today.
Thank you, Dr. Dempsey, for the valuable information. Now I would like to invite all 3 of our experts to turn their cameras on. We are going to open it up for Q&A. So if you have any questions, please type them in the chat. We have received a few questions so far, so I'll go ahead and read them off. And Dr. Joseph, this is a question for you. A participant would like for you to comment on whether adenomous or hyperplasticity cysts found in colonoscopy mean you are likely to develop colon cancer. What is the difference between those 2 types of polyps?
Sure. So whenever patients do get colonoscopies, there are what we call adenomas, there's hyperplastic polyps, there's different kinds, like what the viewer has mentioned. So depending on that, it depends, that can then tell us about how soon after, we need another screening colonoscopy, whether it's 1 year, whether it's 3 years, whether it's 5 years or 10 years. So generally benign cyst, and sometimes those are biopsied. So the advanced endoscopist, the gastroenterologist, will biopsy those polyps to then tell us what they are. And then based on how many they are, based on the size, based if they've actually cut them out during the colonoscopy, then that can then tell us how soon after that patient needs another colonoscopy. So for example, a hyperplastic polyp does lead to increased risks of developing further dysplasia and colorectal cancer. So then those patients would have a sooner colonoscopy versus a patient that didn't have any polyps at the time of the screening colonoscopy. I hope that answered it.
Thank you, Dr. Joseph. And it looks like we have a question for you, Dr. Dempsey. A member of our audience would like to know, what about detection of relapse after a double mastectomy?
So if you are undergoing double mastectomy as someone who carries a BRCA mutation, the idea is to prevent a breast cancer from ever developing, so that ideally there would be nowhere to relapse to because you wouldn't develop the breast cancer in the first place. But say you are diagnosed with breast cancer and you decide to undergo a double mastectomy, which, assuming that that patient is not a carrier of a BRCA mutation, again, is a very individualized discussion and something that our surgeons and our patients really work together to come up with a plan that's right for the patient. But if ultimately the decision was for bilateral mastectomy, then as we go on with your surveillance, we would talk about things like chemotherapy to prevent a relapse, like if it's an estrogen-driven cancer, a pill to affect your hormones to prevent relapse. The way that we detect relapse is with a physical exam with your physician, feeling the mastectomy area to make sure there's no new nodules. And then it's really symptom-based. Is there a new pain in a bone? Do you have shortness of breath or a dry cough that's persistent? Our guidelines tell us not to do full body scans in breast cancer specifically to look for relapse of breast cancer. So it's all based on your symptoms, which is why it's so important to have a good relationship with your oncologist and reach out to them if ever you have a new symptom. Let them tell you whether they think it warrants a scan or not.
Thank you, Dr. Dempsey. And Dr. Kaywin, this is a question for you. A participant would like to know, does a lung screening have any risks or side effects? In other words, how safe is the screening?
So that's a great question, and that's been looked at. It's one of the important things if we're telling or recommending that people get screening. There is a small radiation dose with a low dose lung screening. But when you look on balance between the potential lives saved by doing the screening versus any theoretical risk of slight increase in cancer development, it far outweighs, especially in that risk group that I described, to do the screening.
Thank you, Dr. Kaywin. Another participant would like to know, if you have no symptoms, can a Cologuard test suffice for colorectal screening?
So that's a good question. The answer is yes. So there are other types of stool testing that can be done. However, if that's positive, then that would lead to a colonoscopy.
Thank you, Dr. Joseph. And is there any information regarding risks for having variant PLAB2 gene?
Yes, so POLB2 does raise your risk of a number of different cancers. It portends a breast cancer risk lifetime around 50%. There's also small risks for ovarian cancer and pancreatic cancer. Certainly in patients who have what we consider a POLB2 mutation that is at what we call a pathogenic variant, meaning a mutation that we do think causes disease. We certainly want to be doing, again, these earlier mammograms along with MRI, kind of similar to the way we do for BRCA carriers, starting around age 30, both mammogram and MRI. We would discuss things like preventive mastectomy and removal of the ovaries. Again, it's a very personalized decision between you and your physician, but we would at least have that discussion.
Thank you, Dr. Dempsey. And can a yearly PET scan be helpful to detect some of these cancers?
I'll weigh in on that. So we're asked for years, I've been doing this for many years, is there a test I can do to screen me to see if I have any type of cancer? And to date, there's no one standard test to say, okay, go get this test done, this blood test, this scan, to look in my body to see if I have a cancer. So when you look at cost effectiveness, it's really not recommended that people just randomly get PET scans, for example, to see if they have some type of a hidden cancer. There is a lot of research going on now, looking to see whether there can be testing done with circulating cancer DNA and things like that, that maybe in the future might be promising, but for right now, that's not a standard test. There is no standard blood test or radiographic test like a PET scan.
Thank you, Dr. Kaywin. And we do have a few more questions. And is there any correlation between asthma and lung cancer? Does taking inhalers for years increase your risk?
No. Asthma and lung cancer, there's not a correlation between that, and using inhalers for asthma does not increase the risk for lung cancer.
Thank you, Dr. Kaywin. Another member of our audience mentioned, my mom had breast cancer. Should I have a diagnostic mammogram instead of a screening one?
Diagnostic mammograms are for if you feel a lump in the breast or you're having some sort of breast problem like nipple discharge, or if on your screening mammography something was noted and the radiologist called you back. That's when we do diagnostic mammograms. But even with your family history, you would still be getting screening mammograms as long as you're not noting any kind of breast problem.
Thank you, Dr. Dempsey. And Dr. Joseph, can IBD lead to colon cancer?
Sure. So irritable bowel disease, such as, ulcerative colitis or Crohn's, can increase your risk for colorectal cancer. Again, it depends on the severity of the disease, the duration, which parts of the colon is affected. But generally speaking, at the time of diagnosis, 8 years after, we tend to recommend to start with screening colonoscopies. And then after that, depending on what they find, it'll be colonoscopies 1 to 3 years after that.
Thank you, Dr. Joseph. And Dr. Joseph, how about gastritis? Can that increase your risk of colon cancer?
So to date, I don't think there's any literature for gastritis to cause an increased risk of colon cancer at this time. So not right now.
Thank you, Dr. Joseph. And with that, we do recommend for those with specific questions to continue being in contact with your primary care physician. And I would like to thank Dr. Joseph, Dr. Kaywin, and Dr. Dempsey for informative presentations. And thank you to everyone who joined us this afternoon. We will be sending you a brief survey, and we ask that you please take a few minutes to provide us with your feedback so we can continue planning programs that are meaningful to you. So thank you and have a wonderful rest of your afternoon.
Thank you guys so much.
Bye.
Bye.